And thank you, Anjana, for your kind introduction. I think my presentation will be shorter than his introduction. We'll see. So we start with the ulcer. It's a mainly neglected topic, neglected disease, but it will cause a lot of problems in the future, as well as it is a economic burden as well. So I wanted to give some key features about ulcers. So even if you see the global burden, it's massive, right? So whenever we treat the diabetes and all, it is a massive cost people are spending without knowing, without any knowledge. They are spending a lot of money overall. But even if you take the mortality, it is very high. You can see the major amputation mortality, 5-year mortality will be high compared to all the cancers. So we are worried about cancers, but we don't worry about amputation as well as the diabetic wounds. So even if you see the breast cancer as well as all the cancers, if you take it, still it is very less 5-year mortality compared to the major amputation. And you can see the downstairs. So remarkably, people with diabetes fear major amputation worse than death, even blindness, and even end-stage renal disease. So everybody worried about amputation rather than anything else. So why amputation increase the mortality rate? So we don't think this one, because whenever we get an infected wound, we think that doing the amputation that will get rid of everything. But no, even after the amputation, there are several factors that will increase the mortality. So these are the main factors. I don't go into detail. So mainly the major stress response. Even after the amputation, people have a reduced mobility. So whenever there's a reduced mobility, all the cardiovascular diseases and everything will be aggravated, as well as the psychological factors also. It's important because even because of the depression, even people skip drugs. So whenever they skip drugs, all these conditions will be aggravated. So diabetic ulcers are a silent killer. Why it is silent? Because it is painless. A lot of people, they don't bother. So it is one of the silent killer. And every 30 seconds, there's a lower limb amputation is undergoing in the world, right? Every 30 seconds. So if you see the historical perspective, usually the foot ulcers in ancient Egypt, they thought it is because of the bad humors or a divine punishment. So in humors, they thought there are 4 fluids in the body that will govern our whatever the health. One is blood, the other one is phlegm, third one is yellow bile, and fourth one is black bile. But there's no black bile exist. Maybe they thought about melena and all the other conditions, but they thought like that. So whenever there's a problem with that fluid, that will cause us all the diseases, including the ulcer. So in ancient era, whenever there's a problem or whenever there's a doubt, they cut it out. So they just amputate, they cut it out because they wanted to get rid of all these infections and everything. So usually amputation before anesthesia is a race, and it is a race because there's no anesthesia. So people wanted to cut the limb or amputate the limb within 2 to 3 minutes. So whoever can perform an amputation within 2 to 3 minutes, they became the surgeon, so-called surgeon, but not real surgeons. But that is how the amputation started. So the pain control, usually they used alcohol, right, and opium, as well as physical restraint. But mortality is very, very high. So 2 to 3 minutes is a time limit. So who has taken over this work is butchers and barbers. Okay. So butchers as well as barbers, they have taken over to do the amputation in the ancient era. But little by little, the surgeons also, they have started. Still, there's no anesthesia at that time. So this is one of the famous surgeon, Robert Lister. He can do the amputation within 30 seconds. So he was famous at that time and doing all this amputation. So at that time, people thought whenever there's a pus, it is a good sign. So they don't want to get rid of all this pus because that is showing there's a good sign. So if it's a wound is not having any pus, they thought it is a problem. But whenever there's a pus is forming, then they thought it is the good sign, right? Good sign. So in ancient era, amputation is a treatment. But in modern era, amputation is a failure of management. So it is no more treatment, it is a failure of management. So when we come to a diabetic foot ulcers, there are mainly three types of diabetic foot ulcers: neuropathic and ischemic as well as neuroischemic. Neuroischemic will be the major components of all these diabetic foot ulcers. So that is the main important things about diabetic foot ulcers. So we will discuss a case scenario. There's a 55-year-old farmer. He's a non-diabetes for 10 years, taken treatment from Kemal Seranayake. No major other comorbid illnesses. Develop a plantar callus, right, over the region of first metatarsal head. Then callus was excised in a local hospital and subsequently developed a non-healing plantar foot ulcer, underwent multiple wound debridement, progressive into deterioration of the wound, ultimately required amputation. So where did we go wrong in this? That is the question. So this is, first he came with the callus, then it is forming into an ulcer, and later on it is the amputation. So where we have to address. So first of all, the first thing that we need to do is the prevention of callosity, because callosity is the most important agent or a starting point for all these ulcers. So we have to prevent callosity. So that is the first aim. It's a very simple method, simple ways that we can prevent callosity. If you don't prevent callosity, then that will turn into a wound, diabetic wound. Even if we don't treat the diabetic wound properly, that will turn into an amputation. So there's a question, that is, in diabetes, why people develop an ulcer? So that's a question. So I have asked all this from medical students. The answer was, there's a prick injury they can't feel. So whenever they can't feel a prick injury, that will causes ulcers. So that is not the only cause, because if it is a prick injury is the one it is causing an ulcer, why they develop a callus, right? Why they develop a callus? So all these three nerves are involved when it comes to diabetes. Not only the sensory nerves. So a lot of people think about only the sensory nerve. No. So when the sensory nerve is involved, they will lose the sensation. That is correct. But why they develop a callus? That is the next question. So they have a motor neuropathy also. Motor nerves also it is involved. So whenever the motor nerves are involved, they get a motor neuropathy, they develop deformities, and with the deformities, there will be an increased pressure in some places. Not only that, it will affect the autonomic nerves also. So whenever the autonomic nerves are involved, they don't have a protective cover to the foot, so that will cause us dry skin. Then that is one of the entry to the infection. All that will aggravate whatever the diabetic wound. So why callus forming an ulcer? So repeated unnoticed trauma ultimately causes callus formation because of the foot deformity. For a normal person, what will happen? All the pressure will be evenly distributed whenever they walk, right? And whenever they have arches, they have a spring effect. So whenever we walk, the arches will help. But when it comes to diabetes, because of the motor neuropathy, there will be a deformity and all these arches will be lost, and that will cause us increased pressure to some areas. That will lead to hemorrhage, and later on from the hemorrhage, people develop an ulcer. So how to prevent callosity? This is simple things to do. Daily inspection, everybody knows that. And we have to moisturize the foot regularly. We need to wear a proper footwear to prevent the more pressure in some places. So we have to prevent that, to wear a proper footwear. And gentle foot hygiene as well as drying is again, it is important. So these are few things that is to prevent callosity. If they develop a callosity, that is the next step. So first aim is to prevent the callosity. If they develop a callosity, then what can we do? Then again, we not going for an excision. This is one of the common mistake people do. Whenever people come with a callosity and whenever there's some pain, they complain of pain, we excise. No, that is not the way. Automatically that will turn into an ulcer if it is excised. So regular scrubbing is very, very important, as well as we have to soaking the foot in the warm water, and with the surgical blade we can shave whatever the callosity. And again, using a proper footwear is important. We need to use an antifungal cream. Why? Because the antifungal, whenever there's fungal infection, that is the one, it is aggravates the bacterial infection. So first of all, we need to stop the fungal infections with applying antifungal cream. Then prevention of ulcer, everybody knows in every textbook, people talk about treat diabetes mellitus, treat anemia, stop smoking, manage callosity appropriately. It is there. So in all textbook, it is there. But mainly the smoking is neglected. We treat diabetes, so everybody will be having a very good glycemic control, and anemia also it is treated, but they don't bother about smoking. And even medical personnel, we don't advise them to strictly stop smoking. Why? You can see there are several problems with smoking that will aggravate the ulcer. So we usually think whenever somebody smoke, the blood supply to the lower limb will be affected, and whenever blood supply to the leg will be affected, that is the reason for non-healing ulcers. No, there are several things. That is why I wanted to show this slide. It will inhibit several factors, and that will aggravate whatever the non-healing ulcers. So this is one of the most important thing we need to advise about stop smoking. So now the patient has a wound. So already we have discussed callosity, excised, and now the patient is having a wound. So now we have the question whether this patient will end up with amputation, and if that's so, how to prevent amputation. So there's a simple way to assess this. Every medical personnel should know that. It's called SINBAD. So there are several classification or scoring systems. It comes in whatever the diabetic ulcers, but SINBAD will be the easy way, as well as the you can memorize that very well. There are several other Wi-Fi score and all these things, all are complicated, but just consider SINBAD. SINBAD is Sindubad, like SINBAD. So S stands for site. So whatever the site we need to consider, so that is S. I stands for ischemia, N stands for neuropathy, and B stands for bacterial infection, and A stands for whatever the area that is involved, D stands for the depth. So how to calculate SINBAD score? So you can see now, SINBAD score S, only two, very easy to remember. Site, if it is the ulcer is in the forefoot, it's 0. If it is in the midfoot or hindfoot, it's 1. Ischemia, if it is a pedal pulses are present, it is 0. If there's absent, even at least one pulse is present, it's okay, that is 0. But if the pulses are not there, it is 1. Neuropathy, check whether he is having any neuropathy. Yes, if they have a sensation, 0. No sensation, 1. Whether there's any infection, bacterial infection, there's no infection, 0. If it is an infection, it is 1. Area less than 1 centimeter is 0. More than 1 centimeter is 1. Again, skin and subcutaneous infection, then we consider as 0. If anybody is having an involvement to the bone or muscles, then that is considered as 1. So if you calculate all these things, you will get a score. So why this score is important? Because if it is a score is 0 to 2, it's only the low risk. People will have a low risk of developing an amputation. So anybody is having a 3 to 4 score, 3 and 4 moderate risk. So it is a moderate risk. We need to consider that patient. But if anybody is having a score 5 to 6, that is they will end up with amputation in a very quick way. So we need to address these things quickly without letting them to go into amputation. Okay, so that is why every medical personnel should assess it. If anybody comes to even your father, even your neighbor, whoever, just assess the score here, and depends on the score. If it is a score is more than 3, right, more than 3, patient needs a specialized consultation and specialized management. So how to use the SINBAD score? Number one, site. If the site, so site is one of the risk factors, so we need to go for an offloading. So that is one of the most important one to prevent the amputation. So there are a lot of offloading pressure relieving strategies, that is to relieve the pressure, because already I told you they have a deformity. So because of the deformity, they will have increased pressure in some places. So we need to offload that with something. But there are several methods, several strategies, all are very expensive, right? So all are expensive. You can't ask just a farmer to buy whatever the expensive footwear. So it is not possible. But there's a simple way to offload, right? We can just, something is better than nothing, right? So we know, so just ask the patient to buy a expensive footwear, then they won't buy, they won't wear. So these are the simple way. Even we can use a regiform to cover whatever the wound. So whenever they walk, the wound won't be touched, it won't touch the floor. Even slippers, right? Even slippers, you can just cut space wherever there's a wound. So you can see the previous patient's foot, exactly where they get the wound, you can just cut the slippers, and we can do the offloading without any problem. So that is what we call offloading. If it is an ischemia or absent pulse, we have to refer the patient to any vascular units, and early revascularization is necessary. Neuropathy, again, we can't reverse neuropathy, but we need to go for a protective footwear, daily inspections, and all we have discussed earlier. So that is the important one. If anybody is having a bacterial infection, early diagnosis of infection is very important. All the wounds, antibiotic is wrong, right? It is wrong. So we have to identify infection, and then we need to treat the infection promptly. Area more than 1 centimeter, then we have to keep the environment moist with the proper dressings, as well as we have to assess the depth, and depends on that we need to, if it's an involvement to the bone or osteomyelitis, then we have to go for a osteomyelitis treatment as well. Few things about culture, that is whenever we give some antibiotic, few things about culture. Usually whenever somebody comes with the wound, a lot of people, they take the soap culture just from the superficial part of the wound. That is wrong, because that is a lot of contaminations are there. It won't give exact organism. So we have to thoroughly clean the wound. Then we have to take a deep soap. When we clean the wound, the microorganism won't run, it will stay, right? So whenever we do a deep soaping, that will give the exact culture report. Then according to that, we can start antibiotic, right? And even tissue sample, we can give, send some tissue samples, and all that is helpful for culture. So no more ulcer from just a pulse or just a superficial area of the ulcer. We need to go for a deep soaping. That is the most important one. So how to prevent the amputation when somebody comes with the wound? So we have discussed about the callosity, how to prevent callosity. If they develop a callosity, how to treat, and if they develop a wound, how to treat. That is what it's important, because we need to prevent the amputation. That is our major aim of managing any diabetic patient. So it is called effective local wound care as well as the infection control. So it is called time framework, right? It's again very simple way, time framework, that is to prevent the amputation. One is tissue debridement is important. Then we can go for inflammation as well as the infection control, moisture balance. It's very important. That is why we select proper dressings, right? We select proper dressing, and epithelial edge advancement. So it is very easily, you can remember as time, right? It is a time. So tissue debridement, usually we go for a surgical debridement. That is also, we don't go for an extensive debridement. Whatever the dead tissues or whatever the unhealthy tissues should be removed, not cutting the wounds, but not cutting the whole wounds and everything. So that is tissue debridement, surgical tissue debridement. And you know, there are some other debridement method also without surgery. Even we are using a maggots therapy, right? Whenever we use maggots and also that is also kind of a biological debridement rather than the surgical debridement. So don't think always we have to cut the wound or we have to debride the wound surgically. No, there are several other methods. Even people tried papain and all kind of things are, we call this debridement things. Infection. Next one is the inflammation and the infection control. Usually the microorganism, there will be a pattern, right? They have a microsomal pattern. So first thing is contamination. So this is again when another common mistake, people do a soap culture. Soap culture comes as positive. Then do you want to start antibiotic? That's the question. That is what we call contamination, right? That is what we call contamination. So what is the meaning of contamination? The bacteria is there, but they are not dividing. They are not dividing. They come and go and it is there. So no need of antibiotic for them. Second level is called colonization. So colonization, they are dividing, right? So the bacteria is dividing. So whenever there's a colonization or whenever there's a bacteria is dividing, still the culture will be positive, but still no need of any antibiotic. But cleaning and dressing is very important for prevent the colonization. When if you don't disturb the colonization, what will happen? The bacteria will form a film and that will protect from everywhere. Even if you give IV antibiotic, it won't enter to the microorganism. Even if you put a topical antibiotic, it won't enter because there's an envelope. So because of that envelope, we call it a biofilm. And again, there's no place for antibiotic. Why? Because whatever the antibiotic we give, it won't work. So this kind of a people, we have to go for a debridement or we call wound scooping, right? We have to go for a wound scooping because we have to disrupt the envelope, right? We have to disrupt the envelope. So that is the important thing. Infection, then only we have to call antibiotic. So that is the only place we need to go for an antibiotic because that will aggravate whatever the ulcers. So how do you know whether it's an infection? There will be inflammatory sign, swelling, increase pulse and pain. Patient will be having a pain and there will be a systemic sign like fever. Even some people develop a lymph node enlargement in the inguinal region. All this is indicate there's an infection. So then only we need to start the antibiotic. So again, biofilm we have to manage with the thorough cleaning as well as we have to use some antimicrobial dressing to prevent again to formation of whatever the biofilm. So that is the second we discussed. So tissue debridement. So in time framework, tissue debridement, infection control, that's number 2. Third one is called moisture balance. So what do you mean by moisture balance? The wound should not be dry. It should not be too exudative. So it should be in between that, right? It should be in between that. So moist wounds are better environment. Whenever the wound is having a moist environment, it has a better environment. But if it is dry, it's not good. And if it is too wet also, it is not good, right? So it should have a balance in between that. So that is why we call it a moisture balance. So if you want to maintain the moisture balance, we have to select optimal dressing. Not all the wounds we can use any dressing, right? Usually people use one cream one day and it is not effective or whatever things, then they change to another one. No, that is not necessary because we have to select the optimal dressing according to the wound. So if it is a dry wound, these are the hydrocolloids, hydrogel dressings. These are available everywhere in the market. And if it is an exudative wound, then we have to select alginate dressings or any granular dressing. Even we can use a gauze, right? And all these are considered as an absorptive dressing. If it is a very exudative wounds, then we can use some impregnated gauze as well as hydrofiber dressing. It's very effective. If it is an infected wound, we can use bacitracin, zinc, neosporin. All there are available antibiotic impregnated dressings. So we can use that. If it is a clean but non-healing deep wound is very clean, but it is not healing for a prolonged time, then we can use this vac treatment. You could have heard about that. So vacuum assisted closure, so that kind of a treatment we are using for a clean wound. We can't use that for an infected wound. So proper selection of whatever the dressing is most important for our moisture balance. Moisture balance is the most important one we need to consider when it comes to wound care. So that is important about moisture balance. There are something we don't use it. We never use. There are some dressings or whatever the fluid we never use. One is hydrogen peroxide, then the povidone iodine, acetic acid. Hydrogen peroxide I have seen during my medical student time, and even later on, people clean with the hydrogen peroxide, and you will get there are bubbles and bubbles. Whenever we see, it is very nice. We also happy, right? Wounds also looks happy, but it is not very good. It is not very good, because I wanted to tell you, the neurosurgeons, whenever they do some neurosurgical procedure, whenever there's a oozing, right, wherever oozing, they can't stop bleeding, they use hydrogen peroxide. One of the example in our unit previously, in my previous units, a patient came with the anaplastic carcinoma, thyroid cancer. Patient needed tracheostomy. So whenever a patient needed tracheostomy, we can't put tracheostomy because there's a thyroid, and we can't remove the whole thyroid also, because anaplastic carcinoma, there's no place for surgery. So we have removed only the middle part, and then we have put a tracheostomy. After 1 week, patient came with the bleeding all over the places. It is oozing. So whenever there's a oozing, we can't stop bleeding unless you ligate all these arteries and all. We can't stop bleeding. We use hydrogen peroxide. Why hydrogen peroxide stop bleeding? Because hydrogen peroxide will produce some microemboli. There are small microemboli that will go and block whatever the vessels, and that will stop all the bleeding. So imagine if you use the hydrogen peroxide to the wound is crying for blood, right? Crying for blood circulation, and you are putting all this hydrogen peroxide and make the wound not cry. Not cry means dry. You make it dry. Okay. So that is one of the commonly used cleaning substance, but we never use that. We should not use that. The other one is povidone iodine. Iodine, that is betadine, is available everywhere. People use betadine, but betadine is very good for a dry skin. That is why we are using that for cleaning before surgery. So whenever betadine is mixed with some fluid or some water or saline, the effect of the betadine will go off. So that is why if you are using that for a dry skin, it's good. But if you are using for a wet wound or wherever the places, it is no place. There's no use. Right? There's no use. Not only that, povidone iodine is one of the inhibitor for epithelialization, as inhibitor for granulation tissue. So it is toxic substance to granulation tissue. So if you are using a betadine continuously, it won't allow the granulation tissue to form. It won't allow. So the wound won't heal if you are continuously using betadine or povidone iodine. Acetic acid only be used for Pseudomonas, not for any other dressing. Changing dressing, when it comes to changing dressing, we have seen every time the house officers and all, they write dressing every other day, cleaning and dressing every other day, EOD. EOD is one of the fixed word for every wound. No, that is not good. This is what I told you, optimal moisture balance, optimal moisture balance. If it is an infected wound, we have to clean, we have to change the dressing daily, even twice or thrice daily is important. If it is a wound is having a more exudate only, we have to change daily. A lot of people think whenever they change the dressing daily, that is very good, right? It is very good. That is not, it is like a monkey is pulling a plant and checking the root every day, whether it is growing or not. So when we have epithelialization, what will happen whenever you remove the dressing? What will happen? That epithelial, the nice microepithelial tissue also will be coming with the dressing. So we don't use daily dressing, or it is not, should not be used daily, because unless it is a very much exudative. If it is a moderate exudative, then we know we want the moisture balance, so we can change every other day. But if it is a wound is having a less exudative, we don't have to remove even every other day. Even third day or fourth day will be better. Only aim is to maintain the moisture balance. So moisture balance is the most important one when it comes to dressing change. So whenever we remove the dressing, we have to always give painkillers. So pain management, pain is very, very important. So whenever nurses are changing the dressing, if a patient is shouting, that is not good, right? And even in the clinic or wherever, whenever you change the dressing, always there should be some pain management. And we should do not pull the whatever the dressing or whatever the gauze, because as I mentioned, when you remove or whenever you pull very fast, that is one of the technique, like ancient surgeon, they do amputation within 30 seconds. This is one of the another technique. If you take it very fast, patient won't have any pain, right, or less pain. So no, again you are removing the epithelium, epithelialization and everything that will again aggravate non-healing ulcers. Non-healing ulcers. I've seen people remove dressing by soaking the saline on top of the dressing, whatever the dressing, they put the saline and then trying to remove it. This is not good, it's not correct, because all these microorganisms are on top of the dressing. So whenever you put a normal saline, right, whenever we put up normal saline, what will happen? All these microorganisms will go and settle into the wound. So how to remove the dressing? Always we have to pull the one edge or one side. So whenever we pull the one edge, and then we have to put the saline, or we have to wet the wound on underneath the dressing, not on top of the dressing. So that is to prevent further contamination of the wound. So these are the quick methods, or some methods it's available to prevent whatever the epithelialization. So we need to have epithelialization to heal whatever the ulcer. So time framework, we discussed about tissue debridement, we discussed about inflammation and infection control, we discussed about moisture balance, right, and we discussed about optimal dressing selection. But there's another one is called epithelial edge advancement. What do you mean by epithelial edge advancement? Because whenever people come with an ulcer, there's a edge, right? There's an edge that is surrounds the ulcers, and this, if you have this edge, the wound won't heal. So one of the common mistake is, whenever people come with this kind of a wound, people clean inside. You can see nicely the inside. So people clean insides, and then they put the dressings and all. The wound won't heal. Why? Because there's a crust kind of a edge is there. So if you want to have usually the wound heals from the edge, right? Mostly it is healed from the edge, and slowly it is healed from the bottom as well. So this is what we call epithelial advancement, right? Epithelial advancement. So what we have to do is we have to cut the edge. So whenever the previous picture, when somebody comes with an ulcer like that, then we have to cut the edges of an ulcer. So that is the important management when it comes to epithelial edge advancement. Okay, so that is the important time framework when it comes to any wounds. So always, whenever a diabetic people, some people thinks that whenever there's a diabetic, if they don't have a neuropathy, if they don't have any deformities of the foot, it is safe to do whatever the things. No, even any diabetic patient, they have a risk of developing an ulcer, callosity as well as ulcer. So every diabetic people should have a proper foot care, right? Proper foot care. So when the patient comes, or whenever you see a relation, always you consider SINBAD score. So with the SINBAD score, always you have to assess whether patient will go for a major amputation or not. Then a proper referral is very, very important. And then again, prevention of ulcers, always follow the time framework. So sometimes we have to go for a tissue debridement, but always identify the infection and control. So don't treat any of the ulcers without an infection. As everybody knows about antibiotic resistance, right? Antibiotic resistant, but we talk about that, but we don't care, right? We don't care. Ultimately, we have seen, right? Even the board everywhere we have seen, whenever you send for a swab culture, only sensitive is meropenem. All the others are resistant, meropenem only sensitive. So in that case, all the people we have to grab and give meropenem. So that is not the way. So always treat when there's an infection is there. So whenever there's a colonization, contamination, colonization, biofilm, there's no place for antibiotic. Always we need to give antibiotic if it is infection is there. Moisture balance, again I am repeating that, that is the most important, that is the most crucial part of wound healing, right? That is the most crucial part of wound healing. So select an optimal dressing and do the dressing changes accordingly, not the blanket rule that is every other day. That is not according to the wound. We have to select that, and epithelial edge advancement is important. Multidisciplinary team approach is the proven approach. So there are two teams. This is the proposed model, my proposed model to prevent all this amputation. It's not, we don't have this kind of a models here, right? So we need to adapt that. So it is called TOW team and flow team. TOW team, usually surgical people and all, they will consider whatever the cleaning, debridement of the wound. But there are some flow team, they consider about the blood flow to the limb and all, vascular surgeon, even interventional radiologist, diabetologist. So all that will participate in the flow team. So this is what we call multidisciplinary team approach. So this is what we call multidisciplinary team work. So take home message is there are four pillars of diabetic foot ulcer management: pressure offloading, wound care, infection control, and there should be a good glycemic control or optimization. This is how we can prevent amputation. So don't take it simple or easy whenever somebody comes with a wound. Always you have to have a proper advice, proper management. These are simple ways. There's nothing advanced. Sometimes you might think these hydrocolloids and alginate dressing and all, it's very expensive. Right? It's very expensive. So it is not good if you use normal saline or whatever the fusidic acid or some few things. What will happen if you use a expensive dressing, right? What will happen? The wound will heal very quickly, right? So if you are just doing some normal dressing, what will happen? The wound healing take a longer time, right? It will take a longer time. So think about patient has to come every time to the hospital. They have to pay for 3-wheel or whatever the transport, and they come to the hospital and they come about 50 times to dress the wounds as well as to show the wounds to the whoever consultant or a clinic or wherever. If you imagine or if you calculate all these expenses, that will come less, whatever the expensive dressing, the cost will come less than that. So don't, earlier also we had that idea, we don't propose any expensive dressing, we go for just a normal dressing, but ultimately the time period, with the time period, the cost will be more compared to whatever the dressing. So always select an optimal dressing for a moisture control. Okay, any questions? If you want to ask any questions. Okay then, thank you.